Hello, I'm Emily Mansfield, and today we'll be exploring obesity trends, health systems, and policy responses in the United States, Ireland, and Yemen. It will also be uncovering key challenges and lessons learned about obesity in these nations. Obesity affects countries worldwide. Today we'll be comparing high-income nation, the United States, a developed European state, Ireland, and a developing country, Yemen. Our focus is on health system structures, policy responses, and their impact on obesity rates. So, what is obesity? According to the WHO, obesity is excessive fat accumulation posing health risks. Overweight begins at a BMI that's over 25. Obese begins above 30, and severe obesity is above 40. These thresholds guide global monitoring and intervention strategies. In the United States, 41.9% of adults over 100 million people are obese. 9.2% of these people are going to be classified as severely obese. There are disparities in where obesity takes place. So the Midwest and South have higher rates, along with the lower education levels correlate with higher obesity rates. The Ireland sees obesity in 60% of adults and 20% of children. Environmental, socioeconomic, and genetic factors all play a role. Notably, though, low-income families, especially children, face higher obesity rates, reflecting social determinants of health. Yemen faces a dual burden. Studies show around 58% overweight, 25 to 30% obese, with women about 45 to 54 most affected. WHO data reports 70.1% of adults and 7% of children are overweight, obese, amid conflicts within Yemen because they're going through war. The United States health system is fragmented. Private insurance dominates alongside Medicaid and Medicare, so government sponsored. However, there's still about 10% of the population uninsured, and there's huge out-of-pocket spending. Despite huge spending, life expectancy lags, mortality soars, and access remains uneven. Ireland contains tax-funded public care managed by the HSE with optional private insurance. Ongoing reforms want for universal care and decentralization of healthcare, though, even with integration capacity constraints, continue to challenge health services delivery. Yemen's fragile, conflict-strained system sees nearly half the facilities partly or completely non-functional. Staffing supply and power shortages, along with reliance on external donors like the WHO, underscore systematic vulnerability during the crisis. The United States emphasizes lifestyle changes like healthy eating and exercise alongside clinical intervention like weight loss drugs, surgery, and devices. While there are public health campaigns that tackle diabetes and promote activities backed by research, the United States remains mostly reactive instead of preventative. Ireland uses a whole government approach that taxes sugary beverages, promotes healthy eating guidelines, and social media campaigns. The HSE's model of care spans prevention to specialist treatment, integrating mental health and addressing weight stigma. So they are preventive too. In Yemen, the WHO recommends including nutritional education, front of label nutritional labeling, and beverage packages. Yemen's multi-sectoral nutrition action plan focuses though on undernutrition mostly and not obesity. However, it does help with obesity. Despite major investments, the US efforts have not curbed obesity. Viewing obesity as behavioral rather than a chronic disease limits policy action and treatment. Prevention gaps persist, and taxes on targeting sugary drinks leave out the ultra processed foods. Ireland's healthy weight targets remain unmet. Voluntary marketing codes and reformation policies lack enforcement. Underdeveloped school food standards and uneven sectoral implementation hinders a cohesive national response. Political instability also funding gaps, weak monitoring, plague Yemen. A double burden of malnutrition and obesity coexist in Yemen, and 83% of the population are food insecure inside Yemen. Tracking trends is difficult because of this. Also, there's systematic fragility. Prevalence comparison with the US reporting 41.9% of adults, 19.7% children as obese, followed by Ireland with 6% of adults and over 20% children. Yemen follows last with the best rates of 17% adults and 7% children. Severely obese in the United States is monitored the best, though, peaking over a little over 9%. Comparing system in the US excels in research specialists, but suffer with excessive costs and disparities. Ireland melds public and private care towards universality, yet face capacity strains. Yemen relies on aid and struggles with its infrastructure because of the war. So, strategic review shows that the US uses treatment-focused approach with limited prevention. Ireland has a mixed prevention and clinical approach, but has patchy enforcement. Yemen uses basic education framework, but is constrained by the system fragility. Obesity transcends income levels. It's shaped by infrastructure, culture, policy. Ireland's integration shows promise, but the United States bears the cost of only being reactive. Yemen's fragile state hinders any real action. Comparative insight helps drive future policies like many that the WHO recommends. So thank you for exploring obesity across borders. I welcome any questions and look forward to discussing these with inside our discussion posts later. And